I welcome you for this web series today. Uh, I would just invite the moderators to the session, Dr. Anil Saxena and our Dr. Yash. I think Dr. Ullas is not yet joined in. He will join us in a couple of minutes. So, Dheeraj, please put everybody on the mute. And I request the moderators to unmute themselves and the speakers to unmute themselves. So, over to you, Dr. Saxena.
Yeah, good evening, everybody. It's indeed a pleasure to welcome you all to this evening session. My co-moderator, Dr. Ulas, will be joining in a few minutes. But let us begin the program. So today's session is by Dr. Selvaraj and his team, and they all need no introduction. The first presentation is by Dr. Sakthivel. He'll be talking about AVNRT with absent retrograde fast pathway conduction, a distinct electrophysiological entity. Very interesting topic. Dr. Sakthivel, please, we can start.
I went like
You have to go on the screen sharing mode, please, full screen mode. Slideshow. Okay.
here.
Yeah, click on the
Okay, now.
perfect.
Good evening, everyone. I am Dr. Sakthivel, fellow in electrophysiology. At the outset, I would like to thank my professor, Dr. Raja Selvaraj, and the IHRS team, IHRS, for having me here to present in this forum. So this entity, AVNRT with absent retrograde fast pathway conduction, though it's not uncommon and relatively familiar one, it's still not well studied or published as a single entity. We would like to present it as an entity or syndrome comprising all of its features and also our experience with the same. We also would like to know your insights and valuable comments. So case introduction, this patient, 24 years old male, presented with palpitation on and off for past 4 years with documented tachycardia and adenosine responsiveness. Baseline ECG and echo are normal. Tachycardia ECG shows regular narrow complex tachycardia at 140 beats per minute. Normal axis, RP shorter than PR. RP interval is more than 100 milliseconds and P wave is inverted in inferior leads. So we took him for EP study. To start with, all his baseline measurements are normal. We did V pacing, which showed 1:1 VA conduction with central atrial activation and long VA time. So yeah, the earliest VA was in proximal CS and VA Venki back was at 550 milliseconds and VA ERP was at 600 520. So mentioning about atrial pacing response, which was not actually shown here. So AH jump was present but PR more than RR was absent, and AV Venkiback was at 400 milliseconds, and AVERP was at 600 360. So tachycardia was induced with single atrial extras after isoprenylene infusion. It was narrow QRS tachycardia, cycle length 430 milliseconds, VA 147 milliseconds, and VA relationship was 1:1 in central atrial activation, earliest in proximal CS. So RV overdrive pacing, we did RV overdrive, which showed a VAV response, and PPI minus TCL was consistent with the AVNRT, and its refractory PVC failed to pre-excite. So based on these findings, we diagnosed atypical AVNRT, slow type, and proceeded with slow pathway ablation. So during ablation, we noticed junctionals at a relatively faster rate with VA block. So immediately we stopped at once, but junctionals with VA block recurred every time we attempted ablation. So ablation was done during atrial pacing, faster than the junctional rhythm, and antegrade AV conduction was monitored. PR interval was watched during ablation. Finally, we have given 7 hours of applications over a period of 83 seconds at the slow pathway region and at 30 watts and 60 degrees. Post-ablation measurements were normal. PR was 190 milliseconds. AV Venkiback was seen at 320 milliseconds, and ERP was at 600 to 60. The tachy was not inducible with atrial extras with isoprenylene, and no features of dual AV node physiology was seen. So V pacing was done post-ablation, and VA conduction was absent. So summarizing, this patient with the dual AV node physiology had induction of atypical AVNRT, slow type. During slow pathway ablation, junctional rhythm was observed with VA block, and VA conduction was absent after slow pathway ablation. So we were able to see very few studies in the literature review related to this entity, all just mentioning only the observation of VA block during ablation, but none of them exclusively studied this entity as a separate one. Most of the time, this VA block during junctional rhythm was seen in fast flow type of atypical AVNRT. So in this study from Jiki from Japan, so this junctional rhythm with VA block was reported in more number of patients with atypical AVNRT during slow pathway ablation, and it actually indicates the successful ablation of retrograde slow pathway conduction. So this finding was found to have no relation with the risk of any subsequent AV block. So a combination of 3 features will identify this absence of retrograde fast pathway conduction, as we had seen the atypical forms of AVNRT with the fast pathway not forming the retrograde limb, and no VA conduction during absent retrograde fast pathway limb. Only this slow fast typical AVNRT was not feasible, and this no VA conduction during junctional beats seen during slow pathway ablation. The asterisk is denoting the ablation at the slow pathway region. So no VA conduction during right ventricular pacing post ablation. So all these 3 features will identify this absent retrograde fast pathway limb. So we collected retrospective data of our patients undergoing AVNRT ablation from May 2010 onwards. Nearly 525 patients underwent ablation of AVNRT during this period. So of these, we found a total of 4 patients with features suggestive of absent retrograde fast pathway conduction. Electrophysiology EP study data was analyzed, and follow-up visit data was also collected. So all these patients had no recurrence and no development of any AV block. So summarizing, a small number of patients with AVNRT have a fast pathway that conducts only antegrade. So this absent retrograde fast pathway manifests in the form of only atypical forms of AVNRT being induced, and VA conduction is not seen with the junctional beats during ablation, and it rather indicates the successful slow pathway ablation, and VA conduction is absent after ablation of slow pathway. So knowledge of this entity reassures us that this does not represent fast pathway injury during ablation, and ablation safely continue during atrial pacing to monitor the antegrade conduction.
Yeah, thank you, Dr. Shakti. I think that was an excellent presentation. Now, a couple of questions from my side, and then we can open it to the audience. Um, is there any data on the absence of fast pathway ablation in otherwise, like without AVNRT in general population? Because like in this case, when you did the initial ventricular pacing and the VA interval was rather long, that itself signified that fast pathway is not present retrogradely.
Sorry, sir,
It was
please.
conducting over the retrograde limb only. It was conducting on the slow pathway only. When you do V pacing,
Yes, sir.
so is there any data on the normal population? Like when we do V pacing, typically if the fast pathway is present, the V interval will be short. But in this case, it was long. That itself signified that the fast pathway is not present.
Yes, sir.
So is there any data on the absence of fast pathway in the normal population without AVNRT?
I do not know, sir. I didn't just look for the. We didn't look for that actually. So, sorry, sir. I do not know that.
You get my point.
Yeah,
So
yes,
when
sir.
we when we do when we do V pacing and the VA interval is long, that itself signifies that fast pathway is not present. Otherwise, it would be short, the VA interval.
Yes, sir. But data on such a finding, yeah, I
don't have the data, and we don't see it very commonly also in
Yeah, it's
patients.
very rare, of course.
Very common, yes, uncommon.
Whenever we do EP study for whatever arrhythmia, when we do V pacing, the VA interval is usually very short. But in this case, it was quite evident that fast pathway is absent.
Like you said, I think we can suspect it at that stage itself.
Right.
And the main idea was that when you suspect this and you get a VA block during junctional rhythm, we should not consider that as risk of AV block and just ablate with monitoring antigrade. That was the main idea behind it.
The same situation sometimes happens when the patients with prolonged peer interval present with AVNRT, and we are sometimes scared as to ablating the slow pathway that patient may have complete heart block. The second thing, when do you start the atrial pacing when you deliver the RF energy? Usually we start when we see acceleration. At that point, we start pacing in the atrium so that we can monitor the continued AV conduction or presence of AV conduction during RF delivery.
Exactly. I think yes. Once we know there's a good signal and we start ablating, and we are sure we are eliciting a junctional rhythm there. Once we know that's the junctional rhythm, we want to continue to the full burn. Then we start atrial pacing and monitor while we are continuing.
And is it a normal practice like in all cases?
Yes, we don't do so. But in this case, since patient had a VA block during junctional,
Right.
so we want to
Only in these
monitor in this patient particular patient. So we want to monitor the anti-gate AV conduction. So we paced faster than the junctional rhythm. So drive the junctional and to monitor the PR interval during patient.
Yeah, we usually recommend it in at least 3 situations. When the operator is new, for the first 50 or 100 cases, one can do that. Second is when we have a narrow triangle of cock. That's when we like to do it. And third is when we have a pre-existing PR prolongation, because that is where we have been more concerned about development of AV block. So these are the situations. Any other situation, Dr. Rajan, in your experience?
No, sir. I mean, usually we are able to monitor the conduction by using the VA conduction as a surrogate. So only in this condition, because we are not able to monitor the VA conduction, we have to monitor it antigrade.
Hi, Raja. This is Krishna Kumar.
Hi, Krishna.
Hi. That's a very good point that you brought up. And I just want to say, so if you have AVNRT with retrograde slow pathway conduction, you could ablate the tachycardia by mapping during tachycardia, right? It's one of the conditions where you can do activation mapping in AVNRT.
Yeah.
So just for points, you don't have to go to
science.
So actually, one of the patients who had incessant AVNRT, we had to do that. But the others, like you said, it's an option, but we have generally just gone with the usual anatomic slow pathway. But like you rightly said, all the atypical forms you can ablate by mapping retrograde.
So Dr. Raja, you just mentioned that you monitor the AV conduction by the retrograde VA conduction during the RF delivery. But Dr. Yash has a comment that the both may not be same. Like it may be possible that you lose VA conduction during RF delivery, while the AV conduction may remain intact. Usually, of course, that is a practice that whenever we see any uh, even one beat dropping, we stop the RF delivery. And usually it doesn't affect, we find that the AV conduction is intact. So, but obviously one would not want to continue RF delivery once we lose the VA conduction during RF delivery. Dr. Yash, you can unmute yourself and please give your comment. Dr. Yash, are we there? Dr. Selvaraj, would you respond to that comment?
I think Dr. Yash has gone offline.
Okay.
He was having some problem in the
Okay.
signals. Please go ahead, Dr. Raja. You can go ahead with the comment.
Yeah, no, I didn't actually get the exact question that he's asking. So, like what you said is that there may be a discrepancy between antigrade and retrograde conduction. But like in these cases, what we're saying is that because there is VA block during the junctionals, only way to monitor AV conduction is to monitor antigrade conduction. So we'll just see this once.
Vanita, you can unmute Dr. Yash. He cannot unmute himself.
I will try, sir.
Okay, we've had some typical AVNRT where VA is lost after ablation without affecting antigrade.
Right. Yeah. And the other challenge is, if a patient does not, again, sorry, there's if there's no VA conduction at baseline and you induce atypical AVNRT with retrograde slow pathway conduction, and it's hard to do maneuvers if there's no VA conduction at baseline.
Right.
So either you activation map or you could AP, we reported it like 3 or 4 years back, I guess. So there's a Moradi maneuver where he's compared A pacing in sinus rhythm and looking at the AH interval during tachycardia and A pacing. That's in sinus rhythm. So, but we could also do that by entraining from the A at the same, just faster than the tachycardia rate, I guess, and then looking at the AH interval during tachycardia and during entrainment, and then trying to differentiate AVNRT from a pathway.
You're saying in case of
AVNRT from an atrial tachycardia, you can't have a pathway of this. It's narrow-QRS, right?
Yeah. Okay, I understand. I mean, your point is about cases where there is no VA conduction, you're not able to do the entry. But all these patients, typically, we've had VA conduction through a slow pathway. Does not be.
Can you hear me?
Yes, Dr. Yash, we can hear.
Yeah, there's some technical issues. What I meant was, can you hear me? Am I echoing?
Yes.
Echoing.
Okay, no, because I've opened from. Okay, now it won't echo. Yeah. So what I was saying was that, in this presentation, there was a comment made that only in atypical one that you may use a VA conduction after ablation, which that is true, but sometimes in classic typical rather low fast VNRT, of course, point is well taken. Giving energy, if there's a VA block, you have to stop. But sometimes you're very safely away from region. There's no hiss there by pacing, by validation. It's a safe place to ablate. Catheter is stable, and still you use the VA induction. You of course continue the energy with real pacing. You find absolutely intact AV conduction. You stop the energy, realize VA conduction is gone. So obviously, slow retrograde fast pathway, and yet AV conduction is completely intact. These are cases, I think, the antigrade fast pathway, retrograde fast pathway. That's what I meant.
Yes, yeah, I got your point now. Yeah. So even in typical AVNRTs, you could have VA block repeatedly, and in that case, you can monitor antigrade conduction and still safely ablate. Yes, I expect.
So I think we can move to the next presentation, which is by Dr. Ashish Jain, and he'll talk about coronary sinus ventricular accessory pathways. Dr. Ashish, please.
Good evening to all respected listeners. Myself, Dr. Ashish, pursuing fellowship in cardiac electrophysiology in pacing from JIPMER. Today in this talk, I would like to share some of our experiences from the coronary sinus ventricular accessory pathways. So the first case was a 45-year-old male who came to us with a history of recurrent palpitation since the age of 27 years. Although there was no documented tachycardia, and echocardiography showed a structurally normal heart. So we have taken an ECG in the OPD, and this was the ECG. So here we can see there is an isoelectric delta wave in lead V1 and a positive delta wave in lead V2 to V6 with a negative delta wave in lead 3 and AVF, which suggests a postuseptal accessory pathway. So whenever one is suspecting postuseptal accessory pathway, it is uh, uh, good to see for other ECG finding, which can help us in differentiating endocardial versus epicardial pathways. Mainly, so like the findings in lead 2, AVR, and lead V6. Here we can see there is a steep negative delta wave in lead 2 and a positive delta wave in AVR, which suggests CS ventricular accessory pathway or epicardial pathway. So, although none of these ECG finding is 100% sensitive or specific, the negative delta wave in lead 2 is having a sensitivity of approximately 70%, and positive delta, although and other findings like positive delta wave in lead AVR and negative S wave in lead V6 are less sensitive, but these findings are more specific. So we can see combinedly, as in this case, there is a steep negative delta wave in lead 2 and a positive delta wave in AVR. This strongly suggests CS ventricular accessory pathway. We have taken this. We have taken. We have taken this patient for EP study, and we went ahead with the coronary venogram. So here we can see there is a decapolar catheter in the CS, and CS is hooked with a multipurpose catheter. Although in some cases where we are not able to hook a CS with a multipurpose catheter, we can use deflectable seats. So this is the coronary venogram of the patient. Here we can see a large contractile diverticulum involving the middle cardiac vein. After this, we did the EP study. In EP study, there was HV interval was short, and effective refractory period of accessory pathway was 260 milliseconds. And tachycardia was easily induced with atrial burst pacing, which was a narrow complex tachycardia with a short VA interval, and earliest atrial activation was seen in CS7A. There was a VAV response with ventricular overdrive pacing, and PPI minus TCL and STIM2M minus V2A were consistent with the diagnosis of AVRT. So after knowing that, after knowing the ECG finding, coronary venogram, and EP study finding, we did the mapping in the diverticulum. So here we can see in the schematic diagram. First, we did the mapping in the medial wall of the diverticulum, which here is denoted by a site 1. In the medial wall, here we can see the earliest local activation was 20 millisecond ahead, and there was a QS complex in the unipolar signals. After this, we did the mapping along the lateral wall of the diverticulum, which is denoted as a site 2 here. Here we can see the earliest local activation was only 8 millisecond ahead, and there was a small positive deflection in the initially small positive deflection in the unipolar signals. So these findings suggest that the pathway is running along the medial wall of the diverticulum. So after this, we did the mapping, further mapping in the medial wall of the diverticulum, and we went above near the neck of the diverticulum. Here we can see a sharp potential, which is likely to be a pathway potential, although the local activation is not that much early. It is only 20 millisecond ahead, and there is a small positive deflection in the beginning of the unipolar signals. So we have given the ablation here, which leads in immediate loss of pre-excitation. So a few words regarding such pathway. These pathways are relatively longer pathway as compared to our regular postuseptal accessory pathway, and these pathway expands at their insertion site. So if one is looking for earliest local activation, one that may lead in a failed ablation attempt. So it is advisable to look for a sharp potential, likely pathway potential, which suggests a compact region of the pathway, and giving ablation there is highly successful. Although these sites may have a short local activation duration and may show a small positive initial component on the unipolar electrogram. So here we compared our cases of postseptal accessory pathway, epicardial or endocardial. So we found that the successful ablation site was only 20 millisecond ahead in the cases of CS ventricular accessory pathway, although the successful ablation site in the cases of regular postseptal accessory pathway, it was approximately 33 millisecond ahead. So in all such cases of suspected postseptal accessory pathway, one should look for the ECG markers like steep negative delta wave in lead 2, positive delta wave in lead AVR, or a steep deep S wave in V6. And during the initial evaluation, one should also look carefully for the history of previous failed ablation or development of atrial fibrillation. And all these findings raise a suspicion of CS ventricular accessory pathway, and one should keep a low threshold for the coronary venogram whenever these findings are present. And during the ablation, one should look for the distinct pathway potential. And these sets may not have the earliest local activation and may show a small initial positive deflection in the unipolar signals. So now this is a second case. This is a young male who came to us with a history of recurrent palpitation for last 1 month, and here echo was showing a structurally normal heart. So here this was the ECG. Here we can see there is no obvious pre-excitation in this case. So we have taken this patient for the EP study, and here we can see we have given atrial extra stimulus, and after giving atrial extra stimulus, there is initiation of tachycardia, which is having a 1:1 relationship, and the earliest atrial activation is seen in CS78. And this tachycardia is continuously changing the morphology. Initially, it is normal, then it's going into partial LVVB, and after that, partial RBVB, and last, it's the RBVB morphology. So there was a VA prolongation with the LBVB morphology. So first, I would like to say that regarding some words regarding the VA interval and bundle branch block. So LBB development of LBBB can affect the prolongation of can affect the surface VA. Either it can lead in prolongation of surface VA or sometimes, but it will not affect the local VA. So so this prolongation of surface VA is usually suggests a ipsilateral accessory pathway. So whenever there is a significant prolongation, which is more than 35 milliseconds, it usually suggests a free wall accessory pathway. While if the prolongation is only 25 to 35, like in our cases, it usually suggests a postseptal accessory pathway. But if there is a no prolongation, it suggests a pathway on the opposite side. Like in the cases of LBVB, the pathway like right-sided pathway. So after this, we have given ventricular extra stimulus. So here we can see the earliest atrial activation is seen in CS78, and these signals are fractionated. So whenever one is suspecting postseptal accessory pathway or left posterior pathway, it is very useful to look for the retrograde atrial activation sequence, because the regular accessory pathway activates the left atrium first. Impulse will go from the ventricle through the accessory pathway to the atrium first, and it will activate the coronary sinus later on. While in the cases of CS ventricular accessory pathway, impulse will first activate the coronary sinus, and then it will activate the left atrium. Like in this case, we can see here the local field, star local field potential are seen from the CS before to the far field LA potentials. And one more point I would like to say that these pathways are actually the myocardial extension from the CS muscle core. So whenever we are looking for the retrograde activation sequence, we may see some sharp pathway-like potentials from these CS myocardial extensions. Like in this case, in CS7, we can see there are two sharp potentials. First is from the CS myocardial extension, and second is from the CS myocardium. And there is a far field potential from the LA. While in the distal electrode, we can see there is only a one near field potential and one far field potential. Although in these electrodes also the CS activation is occurring before the left atrial activation. So all these findings suggest that the activation wavefront is going from the left ventricle to the CS and activating the left atrium after the CS. So, as all these findings suggest the CS ventricular accessory pathway, we did the venogram. Although there was no typical diverticulum and there is only mild dilatation in the proximal CS. So we looked for the literature and we found that in one of the largest study by Jackman et al., he reported that the CS ventricular access pathway can have a normal CS, and the percentage in this was given was approximately 70%. So many of such cases can have a normal CS venogram. So this finding. So after this, we did the mapping in the CS, and here we can see there was a sharp potential, sharp pathway potential. We have given the, we did the ablation here, and this leads in immediate VA dissociation. So from this case, I would like to say that these CS ventricular pathway can be a concealed pathway like any other regular SSA pathway, and these pathway can be associated with a normal venogram. So these findings should not be taken as evidence for absence of such pathways. And these pathways are actually the myocardial extension from the CS muscle cord, which runs along the venous tributaries. If one is suspecting these pathways, then it is essential to map along the origin of venous tributaries. And one should always look for the retrograde activation sequence in the cases of suspected postuseptal or left posterior accessory pathway to differentiate between endocardial and precardial pathways. So the third case was a 30-year-old male who came to us with a complaint of recurrent palpitations, and this was the ECG of the patient. Here we can see there is a sudden transition from the lead V1 to V2, and we can see a positive delta wave from lead V2 to V6 with a negative delta wave, lead 3 and AVL. All these findings suggest postuseptal pathway. So like we discussed in our first case, in all such cases, we should look for the lead 2, AVR and 6. But here we can see there are no deep or negative delta wave in lead 2, positive delta wave in AVR or any other sign. So we went ahead with the EP study. EP study was suggested was short HV interval, and effective refractory period of the SSA pathway was 290 milliseconds. There was fractionated potential scenes, fractionated CS potential scenes. So whenever one is seeing some fractionated CS potential, one has to be careful, especially in the cases of postuseptal accessory pathways, because like in our second case, we have seen these may be a CS ventricular accessory pathway. So in this case, tachycardia was easily induced with atrial excess stimulus, which was a narrow complex tachycardia with the earliest atrial activation seen in proximal CS. And during the atrial burst pacing, patient developed atrial fibrillation. So as patient was having fractionated CS potential and developed atrial fibrillation, we did the CS venogram, coronary venogram in this case. And here we can see there is a dilatation of the proximal CS. So as our patient was continuously in atrial fibrillation, what are the options we can think for those? So we thought actually either we can do a cardioversion and ablation in sinus rhythm, or we can proceed with mapping and ablation in pre-excited AF only. So whenever there is a situation like a patient is in pre-excited AF, one has to look carefully for uh, and keep in mind some points like one can proceed with cardioversion and ablation in sinus rhythm, but for this we need either we need drugs for either we are going for pharmacological cardioversion or electrical cardioversion, and these drugs can affect the pathway properties, and these may lead in undue prolongation of the procedure time and sometimes may lead in failed ablation attempts also. And even these patients may develop the atrial fibrillation again. So if patient is hemodynamic, the major thing which we have to keep in mind whenever we are going for mapping and ablation in pre-excited AF is the hemodynamics of the patient, because pre-excited AF can lead in hemodynamic compromise in the patient. And although there is a possibility of development of ventricular fibrillation, it is practically rare. So the main thing which we have to look during mapping and ablation in pre-excited area is the hemodynamics of the patient. The patient is, studies have reported that we can do the mapping ablation in the pre-excited area safely with the success rate which is comparable to the ablation which is done in the during the sinus surgery. So as we monitored the patient and patient was hemodynamically stable. So we decided to proceed in the atrial fibrillation. We did the mapping in atrial fibrillation. And here we can see there was a sharp pathway potential, and we did the ablation here, which leads in immediate loss of pre-excitation. So if patient is developing atrial fibrillation during the EP study, one can safely do mapping and ablation in the pre-excited area with a close monitoring of hemodynamics. And during the mapping and ablation of pre-excited area, one should look for the distinct pathway potential. So in last, I would summarize my talk. CS ventricular accessory pathway are not uncommon and can be a reason for failed ablation. So during initial evaluation, one has to be careful during the history and during initial ECG evaluation. And one should carefully look for the history of previous failed ablation or development of atrial fibrillation, or ECG finding like steep negative delta wave will lead to positive delta wave in AVR or a deep S wave in V6. All these findings may give a early suspicion of CS ventricular accessory pathway and may help in further uh, uh, procedures. And during the EP study, whenever one is suspecting posterior accessory pathway or left posterior accessory pathway, it is very useful to look for the retrograde activation sequence to differentiate between CS regular accessory pathway and CS ventricular accessory pathway, because in the regular accessory pathway, the activation of LA will precede the activation of CS, while in CS ventricular accessory pathway, activation of CS will precede the activation of LA. And these pathway, as we discussed, these are nothing but the myocardial extensions of the CS muscle cord, which runs along the venous tributaries. So whenever one is suspecting CS ventricular accessory pathway, it is essential to map along the origin of venous tributaries to look for an ideal ablation site. And one has to look for the sharp potentials, because these pathways extend at their insertion site, and looking for an earliest local activation may lead in failed ablation attempts. And if patient is developing atrial fibrillation, one can, with a close watch on hemodynamics, one can safely ablate these pathways without undue prolongation of procedure. Thanks a lot.
Thank you, Dr. Jain. I think excellent cases. Any questions from the audience? I think we don't have any question. So, Ashish, some of these pathways may not be accessible for ablation from the endocardial side and may require epicardial access. Any pointers on the mapping towards that these pathways may be epicardial or may not be accessible from the endocardium?
You mean with an
Some of
epicardial
them,
approach?
epicardial, some of them may not be very accessible from with the typical, may require epicardial access. Any pointers that we see during mapping that point towards that we may not be able to ablate them endocardially?
So at least we have never had to take an epicardial route to ablate these pathways. We've never had to do that on the left side, because the CS, it's usually along the proximal CS inner diverticulum or along the tributaries. So at least on the left side, we have not found it necessary.
And usually they can be ablated at the origin, at the insertion of the tributaries. You don't have to go into the veins usually.
Yes. If there are not any questions,
Sorry.
no, nothing. You can ask, please.
I have a question, Dr. Saxena. Which catheter generally do you use for the ablation inside the coronary sinus?
Well,
Do you
we
use
use
the
the
routine catheter or it's the irrigation one?
We generally we begin with the routine catheter, but sometimes we have to use irrigation catheter because we don't want to use high temperature or very high power also. So one can give more controlled delivery with the help of cool tip catheter. But again, we have to be very careful about not giving too much energy inside the CS.
Yeah, I remember one of the talks from Dr. Devinder Mehta. He said that generally, when you have the pathway, which is a CS diverticulum, the pathways will be most commonly present at the neck of the diverticulum, as the Ashish's first case was there. You know, he found it at the just at the neck of the, which is the narrowest part of the diverticulum, and he said probably using a irrigation catheter. I mean, as soon as just the minimum amount of power is achieved, the pathway would go off in a couple of seconds. So I take that tip, of course, from that he has given, and I generally found it very convenient.
Because one of the problem with the diverticuli is that once your catheter is inside the diverticulum, because of low flow situation, the temperature rises quickly and you can't deliver much power.
Yeah, that is why irrigation catheter works very nicely there. Probably that's what his explanation was, and I found it very good. I don't know, Dr. Raja, what do you think?
Yeah, I think for us, about 50% we've used irrigated and 50% we're not required. Sometimes these diverticula are large and the neck is also fairly large, and then there is usually not a problem with cooling. But if it's a little small and at that point you have problems with the tip cooling, then we switch to an irrigator.
Right. Excellent.
Thank you.
Talking of power, Dr. Bala here, do you stop at 25 or you can go up to 35 watts?
So within the CS, we would usually ablate at around 20 watts, 20 to 30 watts. And like Dr. Saxena said, we have to be careful because CS is thin-walled and we can perforate with higher powers. Usually we ablate at about 20 to 30 watts. And generally, we should be able to ablate successfully with
that. The second question is there any role for these new type of catheters, contact catheters, which may have some role?
I doubt contact force is going to help too much here, sir, because, but I don't know. People with Dr. Saxena, somebody with more experience might be able to say.
I don't think it will help. That's typically useful in AF ablation where we are trying to create transmural lines of ablation. But here we are dependent on the electrogram and we just want to ablate the pathway and we are basically monitoring it by the conduction process.
Fine.
I don't think we need that probably. So we can move on to the next topic, which is again by Dr. Sakthivel, and he'll talk about summit VT ablation. So that's another very interesting topic. Dr. Sakthivel, please.
So I'm going to share some of our case-based learnings on Summit VT. So of late, this topic has been presented by many people. So I will stick to the discussion of only salient points pertinent to our cases. So point number one is for position CS catheter deep for all LVOT arrhythmias. So many a time in EP lab, placement of CS catheter during PVC or VT mapping is often overlooked, like the HRA catheter during SVT study. So and we also observed ECG findings may not be revealing sometimes to let us to suspect summit VT. So it is better that in all cases of LVOT arrhythmias, it is imperative to position the decapolar catheter, the coronary sinus as deep as possible, with the distal bipole near the GCV-AAV confluence in the summit region, so that we can compare the activation time there with the other sites within LVOT. So sometimes we may resort to usage of smaller French deca or even quad catheters to take it deeply if conventional 6F deca couldn't negotiate. So point number two is polarity reversal helps identify the site of origin. So sometimes we can observe this polarity reversal in closely placed bipoles, which indicate a site of origin. So in this patient, CS catheter deeply pushed in demonstrated local V earlier by 30 milliseconds at distal bipoles. Along with that, there is a change in the polarity of bipolar region, uh, the form of reversal from CS34 to 12, maintaining the concordance in timing. So this is a pictorial description explaining the polarity reversal at closely placed bipoles based on the change in the direction of depolarization wavefront from the site of origin, which is represented by asterisk at either bipoles. So this was explained in this paper with the schematic diagram showing an arithmogenic focal source within the outflow tract with radial wavefront propagation and the position of the quadripolar mapping catheter. So the distal M1, M2 and mid M2, M3 electrode pairs are simultaneously activated, showing a rapid simultaneous deflection in the opposite direction of the initial part of the electrogram. So which is defined as reversed polarity in the study. So authors of the study showed that the presence of reverse polarity has a high predictive value for successful ablation sites in focal idiopathic outflow tract arrhythmias and is likely to reduce the number of RF applications. So the third point to be emphasized is the use of deflectable sheath inside CS. So we typically start our case by obtaining access into the coronary sinus with a long deflectable sheath manipulated over a decapolar catheter. The deflectable sheath allows placement of mapping diagnostic catheters and wires into the venous circulation, and then if needed, interchange of these with the ablation catheters. So in that way, the venous trauma during the exchange of catheters can be possibly avoided. The fourth point which needs is the use of CS venography. Prior to procedure, we have to define the various anatomical aspects of CS like its length and caliber. So especially towards GCV AAV confluence, its orientation and course and its tributaries near the summit region. So after securing the access to the coronary sinus, we proceed with the venogram through the same deflectable sheath or sometimes using a balloon tip catheter if necessary to delineate the course and caliber of the coronary venous circulation and of particular interest the GCV and AIV with its septal branches. So in one of our patients' venogram, we see the narrowing caliber towards GCV AIV confluence and small communicating branch across the midline draining into GCV. So roughly this is the area corresponding to more basal and inaccessible portion of LV summit close to proximal coronaries. So the interesting fact about this vein is this which drains the GCV is that it's being a divide of perivascular fat and it sits directly on the epicardial surface. It could be possibly a potentially safe as well as effective site to ablate arrhythmias of basal summit origin close to proximal coronaries. So it is familiar that ablation inside the distal GCV requires irrigation, but at times we need to devise optimal techniques for better implementation. So in one of our patients, our attempts to manipulate the Navistar catheter to the GCV were unsuccessful. A 5 French ablation catheter Senjut therapy could reach the earliest site. So coronary angiogram was done, and in one view, the catheter tip was at least 6 to 7 millimeter away from the left main. So we proceeded with the RF ablation here, but it resulted in the immediate cessation of PVCs, but power delivery was severely limited by the impedance and the temperature rise, and PVCs returned. So what was done next was, so we have positioned a 4F multi-purpose catheter, MPA, in the GCV close to the tip of the ablation catheter. And in this way, we were able to deliver better irrigation during RF application. And with this approach, adequate RF energy was delivered and the PVCs were eliminated. So always, point number 6 is always assess distance from coronaries. So obtain views to minimize the foreshortening, and longest distance of more than 10 millimeter would be safe and ideal, and 5 to 10 millimeter would be the gray area where we have to be cautious. So general consensus is that we know RF ablation is not recommended within 5 millimeter of a coronary artery. visualized in at least 2 fluoroscopic projections and at any moment of the cardiac cycle. So it is also important to ensure the real-time catheter position during ablation. 5 French angiography catheter may be left at the ostium to serve as a marker during the ablation. And ablation may also be performed during frequent fluoroscopy to observe for possible catheter dislodgement. So consider intramural focus when there are multiple breakouts with no sites being sufficiently early. So this was one of our patients who presented with bigeminal summit PVC with PVC-induced cardiomyopathy. So this is a overlap of LVOT and left coronary cusp map and distal CS map along with the RVOT map and in a modified LAO view. It's almost like posterolateral view. And activation mapping inside the CS showed the early activation site at proximal to AAV origin, and it was only minus 15 milliseconds. At left coronary cusp, it was on time with the PVC onset. Inside RVOT, it was all late activation beyond QRS onset. So we mapped the LV endocardium below the aortic valve, and the earliest site we were able to find was 20 milliseconds, and it was opposite to the earliest site in the CS. So this asterisk represents possible intramural focus inside the LV summit. So we ablated from here, from the LV endocardium, where we had the activation of at least 20 milliseconds earlier. Initially we started with a non-irrigated catheter, and PVC stopped only after 30 seconds and it recurred after 5 minutes. So from the activation mapping findings, with no sites being sufficiently early, and based on the delayed and transient response to ablation, we suspected intramural focus. So we did a high power and a prolonged ablation from the same LV endocardium with 50 watts over 20 minutes. So we had a complete elimination of PVCs with the irrigated ablation. So intramural foci is highly likely in the summit region based on the activation mapping findings and response to ablation that we discussed earlier. So catheter ablation of these intramural foci remains challenging, and in addition, information regarding how to predict the presence of this intramural foci and best techniques to deal with these VTs is also limited. So in all intramural LVOT arrhythmias in this study by Yamada, so the local ventricular activation during the VT preceded the QRS onset by at least 10 milliseconds at both endocardial and epicardial sites, or at least 20 milliseconds at either endocardial or epicardial sites. The first ablation at the earliest site could be unsuccessful, and it always ends up in the requirement of RF delivery at the opposite side. So there would be the transient suppression of PVCs and it will recur later. This response to ablation is essentially because of the tissue edema and sublethal effect of the RF ablation, since the focus is well within the intramural. So the far field V in the AMC and GCV are highly characteristic of intramural arrhythmias. And if you ablate from the one of the side, the other side will also have the alteration in the EGMs. So the 8th point going to discuss on ablation from multiple adjacent sites. So there exists multiple vantage point to ablate summit VTs. So besides the GCV and the AIV, we can ablate from left coronary cusp and LVOT below the valve, aortic valve, and also the RVOT and LA appendage has been reported. So this patient who had immediate recurrence after the successful procedure underwent redo attempt next day. So irrigated ablation was repeated in the same early site in the distal GCV, but it is of no use. So we proceeded with mapping and ablation in the LV endocardium below the aortic valve at a site earlier by 18 milliseconds, opposite to the early epicardial site. So we went to high power there for longer duration, and also we made use of irrigation and off-normal saline, but all resulted in only transient cessation of PVCs with immediate recurrence. We finally attempted simultaneous unipolar ablation from distal GCV and LVOT endocardium. So at the site, we ablated inside the distal GCV. We had early activation of by at least 25 milliseconds with good QS unipolar. And at LV endocardium, the ablated site was, as already mentioned, it was 18 milliseconds earlier. So unipolar ablation was done with 2 separate RF generators with power up to 50 watts inside LV endocardium and 30 watts in distal GCV, and given for applications given for 1 minute. So with this patient had a complete sustained elimination of PVCs. Simultaneous unipolar ablation delivered with the 2 separate ablation catheters from either sides, endocardially and epicardially from separate RF generators, can increase the current density and tissue temperature in the intramural region, resulting in a better lesion formation by having 2 areas of resistive heating on both sides of the wall. So along with the conductive heat transfer from either sides, greater intramural damage can be expected from the simultaneous unipolar ablation. So bipolar ablation may have a disadvantage in dealing with the intramural arrhythmias, particularly when ablating inside the vein. As compared with the simultaneous unipolar ablation. So bipolar RF delivers the same current to both ablation electrodes, and there may be a significant restriction when a lower power setting is required at one electrode location, like in the smaller vein, to avoid complications. So in contrast, simultaneous unipolar ablation allows the power settings to be individually titrated at both electrode locations. And also the temperature monitor, when we use bipolar ablation, the temperature monitor at either electrodes needs a custom switch box. So in this study by AMDA group, the simultaneous ablation was more often required when the distance between the endocardial and epicardial ablation sites was beyond 8 millimeter. So many a time this LVOT tachycardia or VPCs arising near the anterior epicardial vein may be difficult to eliminate through the coronary venous system. A close anatomical distance of 13.5 millimeter may help identify the most appropriate cases for an ablation attempt from the left sinus or adjacent LV endocardium in the setting. So the last point to be discussed is on this fact that the immediate outcome doesn't always equal final outcome. So one patient who underwent one of our patient who underwent redo procedure, so ablation from GCV, LVOT, and left cusp were tried along with the use of high power irrigation with off-normal saline, but all failed. But simultaneous unipolar ablation from GCV and LV endocardium also failed. But delayed clinical success was evident by 4th day of procedure with significant reduction of burden, and patient completed 9 months follow-up with no recurrence. So we had similarly, we had another case with intramural focus requiring prolonged high-power ablation from LVOT. So partial success was seen at the end of the procedure with at least 80% elimination of the load. And patient, the delayed success was evident by the next day with the complete resolution of the PVCs. So the exact reasons for this delayed effect are not clear, but some mechanisms have been suggested. Could be either due to the lesion extension by the peripheral inflammatory milieu, or by the addition of the microcirculatory damage during the ablation that will result in the delayed effect, as mentioned in this study by posterior necrosis. So it's also this delayed effect is commonly observed in output tract arrhythmias besides AVRT and AVNRT. So the response time to ablation in the study by from China. So this was the response time to ablation was found to be a better predictor of occurrence of delayed efficacy. So in another study from China, the late cure of ventricular arrhythmias in more than 1/3 of patients who have a seemingly unsuccessful ablation session, which is mostly clustered in the first week after the procedure. So this is a plot of change of cumulative ventricular arrhythmias free rate with follow-up time in acute success group and acute failure group. So nearly 68% of patients with acute failure at the end of the procedure, so ventricular arrhythmias were eliminated by the delayed effect of RF during follow-up. So I'll conclude my talk with this slide. So on summarizing my presentations, So always consider positioning the CS catheter deep for all LVOT arrhythmias, and long deflectable sheath would come in use during the procedure when there is a multiple exchange of catheters is contemplated, and also helps in doing the venogram with the same sheath. So always start with venogram and prior to mapping and ablation inside the CS. So assess distance from coronaries in minimally foreshortened views, and consider intramural focus when there are multiple breakouts and no sites being sufficiently early. And simultaneous unipolar elimination could eliminate deep intramural foci. So multiple vantage points should be known to deal with summit VT ablation. And operators may choose a period of watchful waiting before attempting a redo procedure. Thank you.
Thank you, Dr. Shakti. That was an excellent presentation. So I think power delivery within the GCV is a real problem. And there are a couple of things that one can do. You can use ice cold saline instead of normal room temperature. That might allow increased delivery of power. And second, as you already mentioned, the half normal saline, which will increase the virtual electrode and may affect a bigger lesion. My colleague, Dr. Ulas, is already here. He's been sitting quietly for the last half an hour. So I will request him to lead the discussion further. Dr. Ulas, please.
Dr. Anil, you know what? Jipmer is always at the summit.
Yes,
Jipmer,
absolutely.
Selvaraj, they're always at the summit. You know, the way I think Selvaraj made his juniors, the registrars to present such complex scenario of arrhythmia, you know, kudos to him and his team. Great stuff. I think it was Sakthivel who presented just now. Sakthivel, how many cases actually you were witness to? You quoted a few examples, right? How many actually you witnessed to?
Possibly 2 or 3 cases. Witnessed summit VTS. Yeah. Yes, sir.
Actually witnessed.
In my last 1 year fellowship, I have seen 2 to 3 cases of summit VT.
Right. Which one was the most interesting?
Sir, so yeah, this is the case which we have presented, like simultaneous unipolar ablation, where we had earlier from the LV with a good QS match in the digital GCV. So that we had a nice experience.
But do you know that endocardial from the right side? Do you know the activation point? How early it was in that particular case?
In that case, it was LV endocardium. It was 18 milliseconds earlier, sir.
From the right side?
From the LV endocardium, right side.
No, that was a bipolar.
Yes, simultaneous unipolar. So we went inside the LV and give a prolonged ablation, but it's of no use. So we proceeded simultaneous unipolar. But the LV site was earlier by 18 milliseconds, and this GCV outside it was 25 milliseconds.
Well, okay, all right. So now tell me, that was a VT or PVCs?
It's a PVCs.
All right. So now that they were like easily mappable kind of PVCs, or how are they?
Sorry, sir.
They were like easily mappable, or like what? It was tough to have those PVCs.
It's mappable, sir. PVCs were as a patient presented with PVCs, but on table he had inducible VT.
Oh, okay. So you could induce. You could induce easily.
Yes, sir.
You could.
We never had any difficulty in inducing PVCs. Like the most, usually what we see in RVOT output tract that we hadn't seen, sir. Patient had PVCs from the beginning of the procedure.
Right. So you were lucky that it was inducible VT, so that you could actually feel good that at the end of it, you were very sure that what has happened.
Yes, sir.
So that's what actually is the challenge whenever we're talking about these PVCs issues. So you were lucky in that case. Now, what is your advice about when you see ECG? What is your advice when you should be focusing that it could be one of those summit ECGs, summit PVCs on the basis of ECG?
So Usually, in a LVOT arrhythmias, we see a right bundle inferior axis. So we suspect a summit PVCs or VT based on the delay in the initial QRS this initial activation is in the form of QRS slurring, pseudo delta. I mean, all suggesting that many findings towards the epicardial origin. Along with that, some established signs like when it arises near the AIV, we can have a pattern break. So, I mean, we can in any LVOT arrhythmias, it's important to look for this possible summit origins.
Right. Quote 1 ECG. Quote 1 ECG. Here, this is at the DCV anterior interventricular junction. Just quote that example. You tell us the morphology.
Pattern break is that one. Which when the focus is exactly in the midline in the anterior interventricular vein.
So here you don't do anything. You just get in there and then map there, or you map elsewhere.
Yes, sir. We always position the CS as we had mentioned the first point. We position the CS catheter deep inside.
If you don't get in deep inside,
so we'll always attempt with the smaller French catheters.
The heart.
Sorry, sir.
You can perforate the heart. Why should be keeping so deep inside? You can perforate the heart.
We can map inside the LVOT and left under the valve on the LCC left coronary cusp. We'll start with the outflow tract.
Great stuff. Thank you very, very much. You know what? Let me just have this privilege of introducing one of the most respected electrophysiologists, Dr. Selvaraj. You know how proud I am myself because I know him so very closely, because he is associated with our own program at MMM. He's one of the most knowledgeable and most published electrophysiologists of the country, and I mean, my heart swells when I introduce Dr. Selvaraj, and now he happens to be the editor-in-chief of Indian Pacing and Electrophysiology Journal. So it's my privilege, Dr. Selvaraj, to introduce to the audience. And I think I'm going to be learning so much from your presentation now, and I'm sure our junior colleagues are going to be a lot more benefited. Selvaraj, go ahead, please.
Thank you, Dr. Ullas, for the kind introduction. And thanks to everyone in IHRS for allowing our team to present our work. And overall, the series from IHRS has been fantastic. And like Dr. Ullas said, it has been an excellent learning resource for students. And I'm also thankful that we have Dr. Anil Saxena and Dr. Ullas, senior electrophysiologists, appointed as moderators of this session. I think that itself is an honor. So in this talk, I'm going to present a relatively uncommon entity, idiopathic right atrial scarring, and the type of flutters we see in this entity and how we map and ablate these. So primarily focusing on one patient, an elderly male who has paroxysmal palpitations, was initially had flutter, which was thought as isthmus dependent and had undergone an isthmus ablation, but continued to have recurrent episodes. So he has come to us with a recurrent flutter after a previous isthmus ablation. So we'll start off with placing catheters. Like you know, we place a decapolar in the coronary sinus and we have a duodecapolar around the tricuspid annulus. Now, one point here I want to say is we are starting this case with a 3D map, but despite you using a 3D map, it's generally a good practice to keep a duodecapolar still in the RA. So we also did this thing initially of 1 or 2 cases initially when we started 3D not having a multipolar catheter. But I think it is very useful because your 3D is really a summation of activation over time, whereas your a duodecapolar catheter can tell you beat to beat changes that happen. And sometimes otherwise you tend to miss when flutter activation changes when there's not much change in cycling. So it's always, I think, good to have this. And it's also quick to it provides you with an easier ability to identify block when it happens. Now, the other is how to place the duodecapolar. So you could place with the duodecapolar with the distal dipole lateral to the line, or you could place it like this, straddling the line and crossing over into the coronary sinus. Now, placing the tip in inside the coronary sinus, one is it helps to orient it in the right position, how it should stay. That is one advantage. And the other is when you have it across the line, you have bipoles very close to the line, and that makes it easier to identify isthmus conduction or block of conduction. The one problem with this is if you go ahead to do a typical isthmus ablation, generally the ablation catheter rides over this catheter. So you'll have a small part of the isthmus coming under the catheter being protected from ablation. And what we usually do is then you have to slip the catheter under this duodecapolar and then ablate that last part to get complete isthmus block. That is the one thing that happens. So what we do is sort of hybrid. While testing pre and post ablation, we keep the catheter across the isthmus. But while ablating itself, you can pull the catheter back and keep this lateral to the isthmus. So now in the EP study, nothing very remarkable. He has a little prolonged HV and a prolonged AV ventricular, which could be normal. With his age, it's not unexpected. And so the first point here is he is in sinus rhythm. And the first issue was to try and assess if he has isthmus conduction or not. So we are pacing in the coronary sinus here. And a couple of interesting things happen. I'll just show in subsequent slides. But we have the duodecapolar placed there, and this is pacing the coronary sinus. So you can, if you just see here, the activation sequence itself changes on alternate beats. And we look at it a little more closely. This is a schematic of how the catheter is placed. We have 1920 up in the atrium, and then till 1112 is about the mid-lateral RA. 5-6 is on the presumptive area of the line. And these three bipoles are on the medial to the line, while the rest are lateral to the line, and pacing from coronary sinus. So we see the activation in 1-2 to 5-6, and you can see activation, of course, 1-2 is very early because it's close to the coronary sinus os where we are pacing. And then activation proceeds towards 3-4 and then out towards 5-6. So that is clear that you have activation going in the clockwise direction medial to the line. And then on the line itself, we have double potentials here. Now this is partly V also, but you can still see the RA 7-8 that it's quite late. So between 5-6 and 7-8, there's a huge gap. And this is like a double potential. So even though you can look at the timing here and say that it is unlikely this is transisthmus conduction, that is always a soft sign. It's not good to go on timing alone. You should keep in mind that this could represent very slow transisthmus conduction, or it could represent block here with the points lateral to the line being activated by the counterclockwise wavefront. So then we go ahead and look at the activation sequence in the upper lateral RA. And if you see here, it's different. In the first beat, it is starting at 1920 and proceeding in a counterclockwise direction, whereas in the next beat, it's early in 15, 16, 17. What this suggests is that there is crystal conduction. So there's a break in the crista here, and these alternate beats conduct across this break to activate the high lateral RA early, and so that the wavefront proceeds from here in both directions. So it's a little bit uncommon, but it is something that can happen. So like, the crista terminalis is a site where there is actually functional block, and this functional block is maintained by wavefronts coming towards the crista from both directions and colliding there. And especially in conditions where there is scarring in the atrium, actually, if you see the halo electrograms here, you can see it's actually small. We have gained these up to see these electrograms, and then it's a little fractionated. So they're suggesting there is scarring along the lateral RA. Especially in the presence of scarring, this functional block may be impaired and can result in breakthrough across the crista. Finally, the critical part you look for to assess isthmus conduction is what happens in the low lateral RA. If all the activation in the low lateral RA happens in a counterclockwise direction, it's likely that isthmus is blocked. Whereas if you see part of the low lateral RA being activated in a clockwise direction, it may suggest conduction. And here you can see that from 7-8 to 9-10, there is activation in the counterclockwise direction, suggesting there is transisthmus conduction, even though the interval is so long. But suppose you did not have signals in 9, 10, 11, 12. Another way to think of this is that I've just put the signals from here is superimposed as a gray marker here. So what we have done is when there is a crista break, 15, 16 gets activated earlier. But despite activating this early, the timing at 7-8 doesn't change. So even if we activate this side a little earlier, the timing here doesn't change. This suggests that this timing is related to the clockwise wavefront and not to the counterclockwise wavefront, again suggesting there is slow transisthmus conduction. So baseline suggests that there is slow still transisthmus conduction, which we have to ablate. Now we could easily induce flutter, a very slow tachycardia at a rate of close to 100. And during the atrial tachycardia, the CS activation was proximal to distal, and the duodecupular placed across the lateral RA showed a craniocaudal activation. Now, the first thing in this is always to look at the ECG, and especially if there is 2:1 conduction or 1:1 conduction, you may not be able to see the morphology of the P waves well, in which case either look for a pause like this, where like here you can see you can't see well, but there is a little longer pause with a higher degree of block, so you can see the P wave. If there is no pause, you can put in a PVC or put in some ventricular burst to produce a pause where you can see the P wave. Once you can see a P wave, we can look at the morphology, and we can. So first, when we look at the morphology here, and you can see the next P wave is here, you can see there's a long isoelectric interval and fairly narrow appearing P waves. Now, the way we are taught in ECG, we would think an arrhythmia like this with fairly long isoelectric intervals, we would think this is a focal atrial tachycardia and with a rate of close to 100. However, we know that in conditions with extensive scarring, presence of isoelectric interval and a slow rate can be misleading, and despite that, this can be macro reentry. So this is typically seen in settings like post ablation, extensive ablation for atrial fibrillation, or in rheumatic heart disease with extensive left atrial scarring. But this is a rare condition where it can happen on the right atrium. Now, the other thing to do before you start a 3D map is when you, at a point where you can clearly see the P wave, identify what the P wave onset corresponds to with a fixed intracardiac electrogram. Here we are going to use the coronary signer as a fixed intracardiac electrogram, which we'll use for timing reference. And compared to that, this is on time with CS 910. And if you're going to use CS 5.6 or 3.4 as the timing reference, we see that this is about, say, 40 milliseconds before that. So now when we set a window, when we set a window, we can remember that if we set CS 3.4, for example, as this, minus 40 is going to be 0 with the P wave. And if you're trying to map this as a possible focal, we have to see that we go at least minus 70 or minus 100 from the P wave onset, so that you would not miss a focal as re-entry. So this point we had in this one patient, which we previously published, was in a patient with petrology, where the point we wanted to make was, if you don't set the window onset early enough, we are mapping for the whole cycle length, but the window onset is not early enough, coming well before the QRS onset here. Early points can fold back and be marked as late points. And then if you just look at the map, you'll think like you're mapping the whole cycle. And on the colors, you will see head meets tail, and it'll look like re-entry. So a focal arrhythmia can look like re-entry if you choose the window badly. So whenever you choose windows for re-entry, it actually doesn't make a difference how you choose, as long as we try to choose we pick 95 to 100% of the cycling for re-entry. We know about DePonte's method, where you can try to place your window onset right between two P waves, but it really doesn't matter how you set it. But when there is a possibility in cases like this, where it could be either focal or re-entry, see that the window onset is sufficiently early from the P wave onset so that if it is a focal arrhythmia, early points will not be marked as late. Now, the next issue is in a patient like this, where flutter is easily induced, do we start directly doing an activation map, or should we do a substrate map? So just from experience with similar cases like this, we have tended to do a substrate map first in these patients. And this also works with post-MIVT. So what we found is that it's always good to have a substrate map first. You can do a substrate map in detail in sinus rhythm, and that gives you a lot of information later when you're trying to do an activation map. So here we have done a substrate map in sinus rhythm, and I have only one view here for you here, and this is like a right lateral view. This is the SVC, the IVC here, like as annulus. This is the posterior RA, and we have the lower cutoff set at 0.06 millivolts here, and with that you can see fairly dense scarring near the SVC and near the IVC, and there's a line of scar extending from the SVC to the IVC. It's a little broken up. It's dense towards the center, but there are gaps towards the SVC and towards the IVC. And then once we have finished the substrate map, we induce the flutter, and then we do an activation map. Now, the activation map, first we can see here that we are going from about 500 to 105, that is mapping the whole cycle length of the flutter. And if you follow it from red, we go yellow, green, blue, dark blue, and it comes around this. And in the activation map itself, we marked a few points where there are no recordable electrograms. But So the way we usually do the map is, while collecting points, we have two views set up of the same map in RAO and LAO so that you can map without resorting to any fluoroscopy. But while analyzing the map, we keep the substrate map on one side, activation map on one side, and then you can set them in a sync view so that as you rotate it around, you can just easily see how it corresponds. So when you see like this, you can see there's a dense scar here with gaps above and below, and this seems to be re-entry going through these gaps around the dense scar in the middle. Because the other thing you can, if you turn this around, you can see is that you can also see another circuit that goes red, yellow, green around the tricuspid annulus and comes back here. And you could visualize two circuits in your mind. And in these cases, it is always a question, is it actual flutter is around the tricuspid annulus? Is it around the scar here? Or is it a dual loop flutter with both the loops being active? One way to try and differentiate this is to do dense maps and see whether there are a few points going in the opposite direction here. A quicker way to do it is to do entrainment. So a thing like this, what we do is we entrain one area inside this possible circuit and one area inside this circuit. And when we did the entrainment here, we had a ppm anesthesial of 35 milliseconds in the lateral RA, whereas it is quite long at the isthmus. So we know that this is the true re-entrant circuit, and this is bystander activation going in one direction. You can also look at the activation map as in the form of a propagation map, though I generally don't prefer to do this because it's a little more difficult to see what is true and what the computer is showing to you in a propagation map. But for those who are more familiar with this, you can see again the re-entrant activity going around the lateral atrial scar, similar to what you see around atriotomies. Now, the next issue is to consider how to ablate this. Now, all macro re-entries obviously need a line to interrupt the circuit, and a line can be drawn in multiple places. General principles are that a line should always go between two anchor points, and the anchor points can be either an anatomical structure or dense scar. Always preferable to use an anatomic structure because that is fixed and that is a definite true anchor. If you choose a scar as anchor, always be sure to confirm that that is real scar. Make sure there's good contact, make sure there are no electrograms at all. And ideally, we do high output pacing from there to see that you cannot capture in that region. So once you're sure it's a dense scar, you can anchor one end of the line to that. So here, for example, with this circuit, we have a few different lines you can do. You can draw a line from the scar to the SVC, draw a line from the scar to the tricuspid annulus, from the scar to the lower end of the scar, or from the scar to the IVC. So this is just looking at the anatomic based on the substrate map. But you also look at the activation map. And one way to think of the activation map is what I've done is I put a dot in the center of each of the major colors. So there's one dot here in red, one in yellow, one in green, blue, and dark blue. And if you look at the dots, you can see that they're closely spaced here and they're wider here. So that the distance between the colors gives you an index of the conduction velocity. The close spacing here tells that this is the area where there is conduction is slow, and this zone of slow conduction is the preferred area to ablate. So we did the ablation here, closing this gap in the scar between this, and also did a few ablations across the isthmus to get isthmus. Now the next teaching point is that whenever we draw a line, always assess the integrity of the line. So lines, if they are not complete, one is of course a result in recurrence of the same flutter, can also be pro-arrhythmic and result in different arrhythmias coming up. So always assess integrity of line. And in this condition, the easiest way to do it is by pushing the halo catheter posterior to the scar. So most of this you can do again without fluoroscopy, because on the 3D map, you can visualize the catheters, you can put the numbers on and see all the electrodes. So on that, you can see where your scar is and push the catheter behind the scar. And then we place the ablation catheter anterior to the line and pace from here. If there is some leak across this line, activation of this catheter will go from below upwards. Whereas if there is block, it has to come up around the scar, get through this gap between the scar and the SVC, and then come down so that you will see activation coming in a craniocaudal direction. So here you can see the activation comes down in a craniocaudal direction, and this tells us that there is block across the line. This here we can also see simultaneously when you're pacing here, this is the CS, and you can see from pacing how long it takes to reach the proximal CS. This tells us that we also have block across the isthmus, so that it takes a long time to get to the CS. So This condition of idiopathic RA scar is a little relatively uncommon entity. We have seen 5 patients so far. Mostly these are all elderly patients presenting with either persistent or paroxysmal macro-reentrant ATs. One of these patients also presented with a persistent arrhythmia and tachycardia-induced cardiomyopathy. And they have single circuits, or some of them have multiple circuits. And they have a very stereotypical pattern of scar in the lateral RA extending between the SVC and the IVC. And usually it's not a dense line of scar, usually has gaps in between. Almost all of them have isthmus-dependent flutters and require isthmus ablation, but most of them also need additional ablation in the lateral RA along the scar. So this is just a very summary of the scar distribution in the remaining 4 patients, apart from the 5th patient that I presented now. So in this patient, for example, there's a dense scar from the IVC extending up along the RA, and there's a gap between the scar and the SVC. Only there's a single gap, and the arrhythmia was primarily isthmus dependent. We could ablate just between the annulus and the scar. This patient had multiple gaps and had again re-entry similar to this case, and we had to make a couple of lines here. This patient also had multiple gaps, and we had to do a long line. And this patient only had an isthmus. So there is again sparse literature on this. There's one from Australia from Dr. Kalman, Dr. Kissler's group, and they had reported on 8 patients scar-related macro reentry without prior atrial surgery. And this is one from Germany, which was 7 patients. And from India, Dr. Haigrave Rao had reported a single case as an image in EP some time back. So, but all these again basically define this condition as extensive right atrial scarring in the absence of congenital heart disease, prior atrial surgery, or valvular heart disease. And these patients, all of them report again this same pattern of scarring, primarily along the lateral wall, extending from the SVC to the IVC, and often requiring ablation from the scar either to the SVC or to the IVC. And some points is, especially if you have to go from the scar to the SVC or the upper part, you have to be careful about the phrenic nerve. And what we do is usually we keep continuously pacing from the mapping catheter and come along this region. Whenever we see diaphragmatic capture, we put a tag there. That way you get almost a tag of the whole phrenic nerve course. And here, when we had to do an ablation connecting all the way to the SVC, at this point, we skirt around the phrenic nerve. And still, when you're close here, you can still again double check while you're ablating. But from the previous tags, we'll also know how far we are. So always be careful about the phrenic nerve when you're ablating some of this. And so to summarize, this disease is a presence of right atrial scar in the absence of previous surgery of valvular heart disease, and it has been called as idiopathic right atrial scar. Obviously, the term idiopathic means that we don't know fully about this condition. There are various hypotheses for what may be the cause of scarring in these patients. I think currently with the available ways of investigating this, we are not able to identify what is the exact cause of this scarring. These patients tend to have a typical stereotypic pattern of scarring in a linear fashion from the SVC to the IVC, and gaps in the scar or between the scar and the SVC or the IVC usually form the isthmus for macro reentry. And despite this, just as we see with ASD or with atriotomy, the cavo-tricuspid isthmus still remains a very important isthmus in these patients, and almost always it's better to ablate the cavo-tricuspid isthmus. At least one of these patients had what I would call as an unmappable flutter, in the sense that patient was persistently in flutter, and you just start doing an activation map, it switches to another flutter. And then you start a new map, start doing another, within 10 minutes, it switches to another flutter. This keeps on happening, multiple flutters of different cycle lengths. So what we ended up doing is all these 3-4 different flutter maps that we had created, we just combined all the points, used that as a substrate map, identified the scar and the possible isthmuses. And then when there is flutter from these possible isthmuses, you do a quick entrainment to identify which is the isthmus that is being used, and then we can ablate that. So sometimes just doing a good substrate map using entrainment information can work where a full activation map may not be possible. And whenever you draw a line, always confirm block across the line to reduce problems in the future. And when you're ablating in the upper part of the atrium, be careful about the phrenic nerve. With that, I'm finishing that talk, and I want to thank everyone in JIPMER who is behind all this work that we have presented today, starting with Professor Balchander, who has set up the department and has been extremely supported all our activities here. And other faculty in the department, including Dr. Joseph, who was working with us for the last 2 years, and my fellows who are working with me currently. And to people who are interested in training, I just want to remind you that we have an EP fellowship at JIPMER, a postdoctoral fellowship, which is a 2-year program with an intake with starting every June. And also John and me, we do a workshop with a small number of people, usually every February. This is called EP 101, Basics of EP. Although this year, it's still uncertain, of course. Thank you.
Raja, well, you know what, this platform must have been very, very small for such a masterly presentation. And I hope those guys who are going to be applying for your institute are not going to be intimidated by the way you presented. You know, this is a very small platform. I could actually decipher or understand just about 50% of what you could say. So on your behalf, let me tell everybody who has attended here, Raja does simple things also. And you know, he would make the masters out of you. And you know, I hope many of the youngsters are going to be inspired by you, and then they're going to be applying for you, and then they will get into your 2 years course. And by the way, I think you know that we have a 1-year course. So, and with 2 candidates, so let them choose 2 years with you or 1 year with us. Yeah. Now, you know, there's such a masterly talk, but you know, it all started off with some change in the activation. Then the stability of the catheter is such an important aspect, isn't it?
So, I mean, you're saying, is it possible that that was due to catheter movement?
Yeah. I mean, it is just the entire concept, entire thing was just that the decapolar flipped a little bit.
But that's a fairly significant change in activation. So I'm pretty sure that's not due to catheter movement, because you can see the activation earliest.
Yeah. No, you did not really mention that you looked into that the flip of the catheter was considered not to be the change in the activation sequence. So by the way, now how about making things more simple with adopting a newer technology? You know, just putting in, say, for example, H3 grid across the isthmus, and then few of the superior electrodes are outside the line of ablation nearer the CSOs, and few of them just nearer the IVC, and then you are done. How often you are doing that part?
So yeah, I mean, one thing, of course, with JIPMER is that we do 95% of our patients we treat, we do it on a free basis, and we don't have easy access to a lot of the newer technology. So we haven't been using HT grid that much. But this thing came up when we started doing regular 3D mapping also, that when we started 3D mapping, we said, why use all this duodecapolar, and we'll directly do 3D maps. We did a few cases, but especially things like this, I think it's very easy to miss. I still feel it is always better to have a multipolar catheter to be able to see beat-to-beat changes that may happen and pick up interesting things. But I think people are using more of the high-density mapping catheters, and probably you might have a better idea whether in the long term it might make it unnecessary to use additional multipolar.
Okay, one of the last questions is, what is idiopathic RA scar before we get into the EP lab?
How to identify it before we get into the EP lab?
Like, what is this idiopathic RA scar?
Yeah, so like I said, by definition, we call it idiopathic now when there is no patient has not had any previous cardiac surgery, because typically the RA macro reentries, apart from the usual typical flutters, macro reentries are usually related to previous atriotomies. So when there's no previous cardiac surgery and there is a right atrial macro reentry, but the scar is of course diagnosed only during an EPS based on the identification of low voltage regions. So when you have low voltage regions, macro reentry related to those low voltage regions, and there is no prior cardiac surgery to explain those low voltage regions, that entity as such is called as idiopathic RA scar.
This is the diagnosis post EP procedure.
So it has to be actually a diagnosis post procedure.
But obviously there is some atrial myopathy causing this scar. So how are we sure that it is confined to right atrium? I mean, we have not the LA, we have not done any imaging to see there's any LA fibrosis as well.
So in some of the literature I showed, there has been discussion about this, whether there might be additional left atrial involvement or if there might be left atrial involvement in the future. So what we have done is we have tried to treat the clinical arrhythmias. So the arrhythmias that were induced were all in the right atrium and there was no additional left atrial arrhythmias induced. So we have not gone into the left atrium to map that. And in the German series, they had 2 patients where the scar distribution was on the septum. So maybe there is a suspicion that it might be additionally on the left side and probably to go on the left side. But I think most of the other cases reported have been like this, where it is primarily the lateral wall of the right atrium which is involved and seems to be a disease which is limited only to the right atrium.
Great.
These patients have typically not had atrial fibrillation or any other. So just there, Dr. Ashish has been asking. So none of them had atrial fibrillation or had any other left atrial macroreaction.
So is it progressive?
So the patients the follow-up that we have had, we have not had patients having recurrent arrhythmias and seen more scar later, but it is likely, of course, that it could be a progressive. We don't know the etiology of these conditions. It's quite likely that it could be progressive. What people have reported in that other series is also that some of these patients have additional sinus node dysfunction and may end up requiring a pacemaker. We had one patient who had continued to have significant sinus bradycardia. So it is, like you said, it's a right atrial myopathy involving the atrial muscle and probably sinus node to some extent.
Wonderful. I have no more questions except the fact that, what was that kind of a pacing thresholds you got, in a variety of the places? You found it is unusual that you are not capturing?
So
Scar tissue.
it's typically like what you see.
Can't hear you. I could not hear you.
I think they went offline probably.
Vanita and Dr. Yash, sir. Dr. Yash.
Ullas, can you hear me?
Yes, Dr. Yash.
Hello, can you hear me?
Yeah, we can hear you.
Yes, we can hear you. Yash.
Yeah, I had a question for Dr. Selvaraj. Sometimes we take the patients for pacemakers who appear to have 6 signs, and then the certain areas in the atrium where we just don't get P wave, just don't get threshold. And we think this is probably early stage of some idiopathic restricted cardiomyopathy. So this RA scar that he said, is this similar to these patients? Is this the same spectrum where, you don't get, you've seen these, of you all must have seen these patients with 6 signs take for pacemakers and it is just hopeless. You land up either just putting a VVIR instead of the real lead,
Dr. Raja, this is the question for you.
Sorry, we got disconnected for a bit. So you're saying you have patients with sinus bradycardia and extensive atrial scar, and you end up pacing them VVI, and whether some of them may be.
Yeah. So is this idiopathic right scar part of could be in future of the same spectrum?
Yeah, that's true. Yeah, like you said, we have also had these patients who have either unpaceable atrium or extensive atrial scarring and primarily present with bradycardia. And all these patients we presented have had clinical presentation primarily as tachyarrhythmias. But like you said, in terms of pathophysiology, maybe they are the spectrum of the same condition.
Just one point I would like to make about this right atrial cardiomyopathy. There is a condition called persistent atrial standstill or atrial inexcitability. This occurs in patients with facioscapulohumeral dystrophy. It's called FSHD. There are some types of FSHD. And so we had a couple of patients when we were doing initial pacings. We had to do VVA, obviously. And they were all atrial inexcitable. And there were some papers on atrial inexcitability at that time. So maybe they are also right atrial scars or things which are there.
I had one. Hello.
Hey, Dr. Yash.
Yes.
I actually want to, I was that having technological issues, but regarding the CS diverticulum, what I have noticed of more than 100 odd diverticular over years, that ECG, In the ECG, the sign, and this is the juniors, is when V1 is, doesn't reveal itself. Sometimes V1 is positive, sometimes it's equiphasic, sometimes it's Q1, sometimes negative, sometimes like a right inferoparacel, sometimes left inferoparacel. That almost always turns out to be a divertic. This SV6 touching of to the all relative. But when V1 keeps changing its colors like a chameleon, that is almost always there will see a divergence.
So, Dr. Yash, Dr. Allas, Dr. Saxena,
I think it has been a very good session, and we are already 15 minutes beyond our time. Thank you, Dr. Selvaraj. That was an excellent session. Thank you so much.
Thank you, Dr.
Yes.
Thank you, Ulas, and thank you, Yash.
Oh my God. Look at Dr. Yash. Wow. Cheers.
Cheers.
Good night, everybody.
Okay, fine. Thank you.